For everyone who's joined us, my name is Christina Bailey. I'm the Director of Sales for the U.S. I have the honor tonight of introducing the program. I have two other Endologics folks with me. I have the sales manager, Eric Gellinger. He'll help me facilitate. And then Jeff Stodero, our Director of Marketing. So I want to thank the team behind the team for getting all this up and running tonight logistically. But really, the man of the hour, the physician who is offered to help us with education around our polymer-based graft and Alto specifically, is Dr. Nicolas Mouawad. So he's the vascular surgeon at Bay City, Michigan. He is the chief of vascular and endovascular surgery, chair of the cardiovascular research, vice chair of the Department of Surgery, and medical director of the non-invasive vascular laboratories at McLaren Bay Regional Hospital. He received his medical degree from Royal College of Surgeons in Ireland, completed his residency in general surgery at St. Joseph's Mercy Health Hospital System in Ann Arbor, Michigan, and his vascular surgery fellowship at the Ohio State University, Wexner Hospital. So I got a little tongue twisted there. But Dr. Mouawad, it's a pleasure to have you. Over the last few years, I've gotten to know you very well as a physician, also I'd say as a friend. We appreciate you supporting us tonight. We have a very full audience. Eric will help facilitate, but the floor is yours.
Thank you so much, Christina, and thank you to Endologics for the opportunity to discuss this tonight. Thank you all for tuning in. I know you're all busy, so I appreciate your time and I appreciate the opportunity to talk to you all. We're going to discuss the role of adaptive sealing technology, basically in clinical practice. And I'm a big fan of polymer-based endograft, which the Alto device can support. Christina's been very kind with her introduction, but I'm just a regular vascular surgeon in the mid-Michigan area. Here are my disclosures. And why are we here? We're here because we want to talk about providing a durable solution for aneurysm-related disease. We know that EVAR has really taken off. Over 80–85% of aneurysms are repaired with EVAR technique. But if you're really involved in managing aortic aneurysms, you know that aortic neck dilatation really is the Achilles heel. It's very difficult to deal with if it's a problem, and the goal is to avoid that from happening up front. So we know that aortic neck dilatation is relatively common after EVAR, and with it comes further problems. So you can see to the screen left, systematic review of multiple studies shows that patients, or around a quarter of patients or so, have aneurysmal neck degeneration. And it's just a few amount of those patients do not. Importantly, to the screen right, when you have aneurysmal neck degeneration, you basically lose fixation, which can cause migration, and you lose seal, which can cause a type 1A endoleak or an endoleak of any sort, as a matter of fact, but type 1A in particular, if you lose seal at the proximal aortic neck. And so those things are very, very challenging because, of course, if that occurs, then the aneurysm can continue to be pressurized, and then the patient is not protected from aneurysm-related complications, in particular rupture. So review of the data shows that a quarter of patients with EVARs have aneurysmal neck degeneration. Why is this happening? Well, it's actually, when it comes down to it, relatively simple physics. Most endografts out there are self-expanding stents, and the goal of the conventional endograft primarily is to seal the aneurysm by basically oversizing. That's how we're all taught. 10–20% oversize. You get a 25 millimeter neck, you put a 28–30 millimeter endograft, and the goal is to basically obtain seal by oversizing the self-expanding stent. And you can see here from physics and a stress evaluation diagram that there's a significant amount of stress placed on the infrarenal aortic neck. And actually, when you think about it, that's on purpose. That's how they were built. You put a larger stent in a smaller vessel, and that kind of hugs the walls and gives you the seal that you want. But the goal of that stent is to, over the course of time, release that potential energy because it wants to get to its nominal size. So if you're putting a 28 millimeter stent in a 25 millimeter vessel, for instance, it wants to get to 28 millimeter, even though the next 25. So over the course of time, there's a significant amount of stress. And the concern is ultimately you'll degenerate the neck. Well, it's not just a concern, it's a fact. We see that in the data. Oversizing endografts causes neck dilatation, and that's because of the mechanism of action of self-expanding stents. So you can see that over the course of time, they want to get again to their nominal size, and the neck enlargement is essentially related to the degree of stent graft oversizing at the time that you implant that particular stent. So if it's a 20% oversized, it has a larger aneurysmal neck degeneration than if it's a 10%, because it wants to achieve that nominal size of the stent. And actually, the physics property is called hoop stress, is what it's actually called. I'd like to read this because I think it's important. And I quote, "Neck dilatation following EVAR is a well-known event, particularly with oversized self-expanding endografts, because of the chronic outward radial force on the infrarenal neck. In addition, the infrarenal neck has been demonstrated to be histologically diseased, which may lead to progressive dilatation." So we know this, yet we continue to use conventional based concepts despite having aneurysmal neck degeneration. And ultimately, for those of us that deal with a lot of aortic disease, it becomes much more challenging down the line to be able to manage those. Diagram here kind of to show that again. You have an untreated aneurysm to the screen left, and there's outward force from the blood pressure. And so our goal as vascular surgeons or interventionalists is to basically remove the outward force and the law of Laplace to disallow the aneurysm from getting larger. So we want to remove that blood pressure by placing a stent graft. And in the middle, you can see this is a self-expanding stent, which obtains its seal and fixation by oversizing at the infrarenal neck. And that's why the neck is important. You have to have 10, 15 or so millimeters, because you want to be able to obtain your seal and obtain your fixation. However, their force is additive because there's outward force from the blood pressure and there's outward force from the energy of the self-expanding stent. So both of these continue to put an outward force on the infrarenal neck, ultimately causing the neck to get larger and have neck degeneration and ultimately failure by either a type 1A endo leak or migration, which will ultimately pressurize the aneurysm sac. So if we look at some stents, we can see, frankly, that if, excuse me about that. I apologize. You can see that self-expanding stents here that are placed in the picture, as they continue, how outward radial force will ultimately cause the neck to degenerate, and then all of a sudden the self-expanding stent is floating. Whereas to the screen right, you can see a balloon expandable stent, which is still there, has not gotten larger because it stays at its nominal size, and now in fact floats within the infrarenal neck because it has no further opposition, because the neck itself has enlarged. And so it's important to understand that concept that this continuous outward radial force is a mode of failure in the sense of causing the infrarenal neck to continually expand. Enter the Alto endograft and polymer-based endograft, frankly, which offers really a personalized approach to management of each aortic aneurysm. It has a broad indication. It's very durable, and so really, in this concept, you have obtain an infrarenal seal and an infrarenal fixation, both of which are separated from one another, and I'll discuss that a little bit later on, where you obtain a seal at a very specific area on the infrarenal neck. And with the Alto device on label is a 7mm infrarenal neck indication. So at that 7mm mark below the renals, that's where you obtain your seal. And it's very personalized to each patient by administering the polymer and obtaining that seal. So, and we use the disease, you can use the disease at the infrarenal neck to assist you in obtaining that seal. Furthermore, as we'll see in subsequent slides, we can treat many more aortas or aortic aneurysms that are on label with this device due to access to the infrarenal neck and to the juxtarenal angle. Furthermore, there is no outward radial force when you use polymer-based endografts, such as the Alto device. To the bottom part of the screen, again, just to touch on that, 7mm neck on label indication, 7mm, and a 13 French delivery system, which is the smallest out of any delivery system for abdominal aortic aneurysm repair. Going back to our initial stress graph, to the screen left, you can see that with a conventional stent graft, which exerts outward radial force. However, to the screen right, again, there's only one band there, which gives us the seal. And that's where you select to place your infrarenal O-ring, as we call it, at the IR or infrarenal 7 position, 7mm 7 position. So there isn't across the entire neck, just the one area that you plan to place your seal. And so the remainder of the neck, technically, the remainder of the neck is protected. The adaptive sealing technology kind of started, with the Ovation Prime, Ovation IX, and now we're talking about Alto with a polymer-based concept, where you can use even the disease of the infrarenal neck to assist you with obtaining a seal. So you can see to the lower part of the screen some calcium. However, it's like caulking your wall, where you can place this and obtain the seal that you need. So this is very adaptive to whatever wall or infrarenal neck that you're dealing with, and really allows you to conform to the patient's native anatomy. Furthermore, with the application of the polymer, it avoids outward radial force and protects the neck at that level from the blood pressure. So really obtaining a stable neck diameter for out to 5 years of the data we currently have. And I think that's very important to know. Again, this allows us as vascular surgeons to be able to obtain a patient-specific seal at the site that we want. So at the IR7 position, which we're interested in, is where we'll obtain that particular seal. And again, the seal itself is separate from the fixation, which is these suprarenal stents, and we'll discuss in subsequent slides. So really, you look at this, you measure it to each patient's particular anatomy, and again, on label was 7 millimeters. Furthermore, once the initial part of the graft is deployed, or actually the suprarenal stent, there's an integrated compliant balloon to really allow appropriate molding or opening of that of the suprarenal stent. And ultimately, when the polymer is deployed completely, you can mold that appropriately to the patient's infrarenal neck with a compliant balloon that's already integrated. This really kind of shows the concept itself. Again, from a de novo native aneurysm, the screen left, in the middle using conventional endografts with a self-expanding stent with the outward radial force of the stent and the blood pressure, versus the polymer-based endograft or the Alto with this adaptive sealing technology, where we select where we would like to obtain the seal using the polymer O-ring, the suprarenal stent for the fixation, and basically protecting the infrarenal neck and the aneurysm itself from force. So there's no outward force, there's no outward pressure, and blood pressure itself is excluded by causing it basically to bounce back more proximal. So that all results in no neck dilatation, which is exactly what we're trying to avoid, because we want to protect the patient from aneurysmal consequences. Whenever I look at medical devices or endografts and deal with industry, it's important to be able to partner with people that continue to iterate and innovate. Take a look at what happens, what we can do better, where the opportunities are, where the challenges are to make things better. You can see this is not something new. It's been going on, iterative of multiple years, starting the trivascular graft to the screen left, and ultimately at this point now with the Alto endograft. And I can say, you know, having been involved with polymer-based technology for many years, a lot of these changes were actually physician-centric. We relayed our concerns, relayed our thoughts. How can we make things simpler, better, ergonomic, visual, radiopaque, and so forth? And I think that's very important, because it allows us to iterate for the physician in a physician-centric manner. So that's very, very important. And again, over 25,000 or so implants to date. Initially, it's something that you have to get used to. So you can see when you obtain the seal with the polymer-based endograft at the level of the Alto device at the infrarenal neck, a lot of times when we look at it, you see the O-ring, and you're like, well, is that encroaching on my lumen? I'm a little bit concerned about that. There are 5 sizes, 5 main body sizes. And you can see from all of them, even the smallest one in the middle of the screen in red, you can see the inner bore diameter is 15 millimeters up to 26 millimeters. So you don't lose laminar flow down the middle part of the graft. That's something important. I was concerned about that myself. And in the beginning, I would check it, take pictures. I would use balloons to see if the balloons would inflate. Well, I even did IVUS in the beginning just to make myself comfortable. And 100% of the time, I was relieved, because there was no luminal encroachment of the infrarenal aneurysmal segment. So there is still good flow, and you don't actually lose the flow channel down the middle of the aneurysm. And I think that's important. And I urge you guys to check it yourself if it's something that you're concerned about. But I can tell you again, here you can see it on the graft, and I've even checked it as well. So that's important to keep that in mind. Okay, so you don't lose your laminar flow down the middle part of the aneurysm by having the polymer fill on the lateral walls. On label, 7 millimeters. And that's a complete game changer. It's actually changed a lot of my fenestrated work, because now I can take care of a lot more patients on label, not worrying about aneurysmal neck degeneration down the line, even in my own personal practice, just multiple years using polymer-based technology. Again, you have to worry about where you're going to place that seal. And it's a different thought process on managing patients that have self-expanding stents, because let's just say you're like, well, we want to oversize by 10, 15, 20. Oh, let's go hug up or let's hug down. You can think, sometimes we think that way when we use conventional base endografts. In these, it's a little different. You have to, if you're not comfortable, you have to rely on your representatives. But once you become more comfortable, you have to understand that where you plan to deploy a polymer is where you're going to obtain seal. So in a neck like this, if you decide to come a little bit too low, you may not obtain seal because it's the aorta is a little bit reverse conical, and so that makes it a little bit it's a conical, excuse me. So it makes it a little bit more difficult. So it's important to decide where you want to place your seal and stick with that. And that's something that the reps can help you plan in anticipation for your case. Again, 7 millimeters on label, less than 60% juxtarenal angulation. We'll discuss that in the next couple of slides. Again, 16 to 30 millimeters is the on label evaluation. You can even use thrombus as part of your seal, but it has to be less than or equal to 8 millimeters. Here are just some representative images of some of these, which we can still maybe consider them complex necks, others maybe not. But you can see in the top part of the images, the untreated, and then on the lower part of the image, you can see them treated. I'll just draw your attention again, just because I think it's important. If you take a look at the middle picture and the bottom of the post, where the rings are nice and beefy, and you can really see them very dominant. Again, the concerns are, well, does that really take away from the inner lumen of the aorta? And no, it does not. Again, based on that previous slide that I showed you, maintaining appropriate luminal flow down the middle, despite whichever main body you select for the aorta that you want to treat. So I think that's very important to keep that in mind. Using polymer-based technology in the Alto, we look at the juxtarenal angle, and that's really measured by measuring the angle on the lesser curve and then basically looking at the position at the 14 millimeter below the lowest renal. Again, the reps can help you with this. It's a little bit different than looking at the infrarenal angle, which I'll show you on the next slide. But you administer the polymer from the channel on the device itself. It basically goes up its lateral limb, fills a proximal ring, then the distal ring that comes down the contralateral side. And this really adapts to the patient's own anatomy and hugs the aortic wall, whether or not they're thrombus or not. Again, you can see here to the screen left, the infrarenal angle would be 89.3 degrees. However, the juxtarenal angle is measured in the middle part, which is a little bit different, and that is less. That is 18.9. Again, on label for less than 60 degrees of a juxtarenal angle evaluation for patients. Another one of my cases here, very complex. Consider neck, challenging to do with other based endografts. Be also challenging, probably open, but you can see here you're able to obtain seal, and this is on label because of the juxtarenal angulation of less than 60 degrees. To put that in mind as well, sometimes these are very difficult to cannulate via traditional retrograde technique. So you can use the contralateral up and over technique here, where you pass a wire, you can snare it from the contralateral side. And this way you don't have to worry about the multiple angles, making it much more complicated sometimes to be able to get traditional cannulation. Importantly, and we spend a lot of time talking about the infrarenal neck, and that's really important to obtain that seal to avoid aneurysm pressurization. But the delivery is also important. You can't treat the aneurysm if you can't reach the point of pathology. And so this device is the lowest profile device on the market, 13 French. And the reason this is possible is why. It's possible because you separate the seal, which is a polymer, from the fixation, which is the 3.5 centimeter suprarenal stent. And by disassociating the two, the only metal you truly have is a suprarenal stent, allowing you to have a very small profile delivery system. Once that's delivered at the site and you obtain your fixation by deploying the suprarenal stent, at this point, you worry or plan on obtaining your seal by administering the polymer as you had calculated along with your rep ahead of time. So that keeps you on a very low profile and can keep everything PVAR as much as you like. It's optimized for small access and very tortuous vessels. And so I don't even worry nowadays about access, but delivering the endograft anymore, because I know that the Alto device can get there and keeps a small profile as possible. very flexible, and can manage tortuous anatomy. But again, you can see to the screen right, separating this fixation from seal is what allows you to have this very small profile. And ultimately, after deploying the main body or getting there, deploying your main body, using this compliant balloon to mold it, using this adaptive seal technology, administering your polymer, you're happy to allow all that. You have to, of course, extend with to the bilateral iliacs, and the ovation limbs are excellent. They're PTFE based. They have a helical nitinol configuration, very, very flexible, and really no significant concern at all due to graft occlusion. You can see 97.2% freedom from secondary intervention due to graft occlusion, and even more complicated or complex tortuous iliac anatomy. It tracks very nicely, and it's very radiopaque, so it's relatively easy to see on fluoroscopy. Here again, some of these more tortuous iliac cases that we have, ultimately the deploying of the Alto endograft conforms quite nicely, low profile, excellent seal, and really adapts to the patient's own anatomy quite conveniently. I mean, and I tell everybody, you know, even though I've done a lot, I mean, a lot of these, you know, I don't just say, don't just take my word on it. There's data to support this. There's data to support polymer-based technology and polymer-based endografts. The encore analysis here, you can see as a retrospective analysis of almost 1,300 patients that demonstrated favorable clinical outcomes. When we say favorable, we mean durability at 5 years by successful aneurysm exclusion and low aneurysm-related mortality. And just in full disclosure, this was based on the Ovation IX platform. So Altos wasn't part of this, but it's polymer-based technology, so the same concept. You're out to 5 years in the Ovation pivotal trials, Lucy in women, and so forth. But again, 99% freedom from aneurysm-related mortality, rupture, and conversion, 98% freedom from reintervention for type 1 endoleaks, and 90% freedom from device-related intervention. So a very robust data set looking at polymer-based endografts. We started discussing adaptive sealing technology, showing low rates of proximal neck dilatation and degeneration. And that's extremely important. I believe this is all secondary to a physics concept, because there is no, again, outward radial force on the infrarenal neck that is additive when it comes to the blood pressure that a lot of our patients have due to hypertension. So 97% at 1 year, freedom from neck dilatation, 93% at 5 years. Very, very, very excellent results when it comes to that, despite patients having challenging anatomies. And again, here they define that as those that are outside the IFU for other devices. So in the beginning, when I decided to use this, it was because other grafts that were off-label could not provide a solution for my patients with aneurysm-related disease. So using this, despite other ones being off-label for other ones, still demonstrated significant and appropriate results. The elevated ID reinforces Alto, and again, the adaptive sealing technology. This is the pivotal trial for Alto. Again, 100% freedom from aneurysm-related mortality and rupture, very high freedom from conversion, and again, no migration, no device occlusions, and that's very, very important again. So just to kind of show you that there is data to support this, you're not just listening to me and my anecdotal experience, which is quite comprehensive, but there's data to support all this. And then ultimately Jaguar, so much so that they're actually, Endologics is doing a trial that was mandated by the FDA, basically comparing Alto to commercially available comparator devices, including the Cook, Medtronic, and the Gore excluder. And they're going to be following patients at 1 month, 6 months, 1 year, and yearly thereafter for 5 years, up to 60 sites in the US. And what they're looking for is aneurysm-related complications and type 1A endo leaks and device migration, the usual things that we look for in aneurysm related care. So much so that we're comparing it against other commercially based devices to see how it does. I feel like I've been talking a lot about some didactics. We'll talk about a couple of cases just to kind of go through this. You can see here, and I'll let these run, 82-year-old male with a 6.2 centimeter aneurysm identified incidentally when he went to his chiropractor. Clearly, it's achieved threshold for surgical repair at that size. You can see the gallstones, and you can see the aneurysm kind of almost like a double bubble that will show up here, enlarges a little bit more in the distal aspect. 60-pack history of tobacco use, COPD, and on hypertension. So this is what the pre-op CTA looked like. looking a little bit more at the access, and again, some anterior calcium to the left common femoral artery, but I don't really worry about access anymore, primarily with the alto endograft. So 6.2 and change of the maximal aortic diameter and minor access, and you can see here the screen left. So 10.1 millimeter infrarenal neck with a right lateral bulge, if you will, to the aortic aneurysm itself. So automatically, commercially based endografts that require 15 millimeters are off the table if you're going to continue being on IFU. 10 millimeters, some of them you can do on IFU, and you can see here in the middle part again. I'm only concerned about the 7 millimeter below the lowest renal, which is the left here. That's where I'm going to obtain my seal, and that's what I'm concerned about. So my plan is to obtain seal at 7 millimeters below the lowest renal. You can see the screen. This was the plan, which was putting a bell bottom on the right to 22 millimeters, and we had to extend with 2 limbs because it was just so long to the distal left common iliac artery, just proximal to the bifurcation to the internal and external. So the plan was to place 2 of those. Standard. I'll remove the sound there, but there you can see the aortogram. My plan was to go percutaneous, right-sided access for the main body. So I placed my pigtail on the left to obtain my imaging. It's the bilateral renal arteries, and again, confirmed what the CT angiogram showed with kind of a right lateral bulge to the aortic aneurysm at the infrarenal position. Tend to mag up at this level just to really look at the suprarenal segment, and I'll just go through this with you all, just so you can see. So this is the suprarenal segment. It's actually not the endograft. You don't see the endograft because there's no polymer in it. All you see is a suprarenal stent, which is the only metal that's in the device, nitinol that's in the device, allowing us to have a small, low profile delivery system. If you look up here, actually, there's a marker. It's an eye. This is because it's the ipsilateral limb. So I actually was crossing this. So the ipsilateral limb was actually to the patient's left side. And so the contra limb will be on this side, and that's how you can tell them on those markers. These are advanced above the level of the renal arteries, and then the first nested knob is deployed, so you can basically see these markers. These markers are 2 millimeters in length, and their goal is to be placed in the mid portion of the renal artery. That gives us where we can be sure where our 7 millimeter infrarenal 7 millimeter mark is going to be to deploy the polymer, where we're going to obtain that seal. So it's deployed, partially deployed there, so we can see those. We put it in the appropriate position that we want, and then at that point we deploy that portion. You can see over here, following deployment of the proximal segment, we do the regular retrograde imaging, so we can be able to tell what our lengths are going to be towards our hypogastrics bilaterally. You can see to the screen right here that the polymer is already there. At that portion, I'll show you better pictures here shortly. And then ultimately, after the polymer is deployed and we're able to obtain a placement of our bilateral limbs, we go ahead and do some balloon angioplasty of these very, very low atmosphere. The goal is just to be able to get good apposition into the bifurcated main body limbs. Those are 11 millimeters in diameter. So I usually use a 12 millimeter balloon, go up to around 4 atmospheres just to basically get some nice apposition along those within the main body device. Then the limbs basically extend down to their respective hypogastric vesicles. And you can see here in completion imaging, I'll kind of let that play, but in completion imaging, you can see the well-positioned endograft, no evidence of endo leak, and complete exclusion of the aneurysm sac. Again, the seal is obtained with this proximal ring up here at the top. This one's just to allow better delivery of the polymer, but it goes up the proximal, the ipsilateral limb, fills the proximal ring, comes down the secondary ring, and then fills the contralateral segment, and then basically comes down the contralateral side. And now we've obtained our seal, and there's no, again, evidence of endo leak or evidence of filling of the aneurysm sac. And again, here is some things that, like I said, people get concerned. They're like, well, is it not bulging into the aneurysm? As you can see, the flow is kind of in an hourglass pattern, but again, the middle portion is maintained, and there is no encroachment on the middle portion of the lumen of the endograft, and continues with this flow. This is a 4-month CT. Some things that people tend to get concerned about, especially when radiology takes a look at these, because you see the suprarenal stent and you see the limbs, but you don't see the middle portion yet. on CTA imaging. And so they a lot of times think that the endograft is completely disassociated from itself. That is not the case. It's just the way the polymer is until it becomes completely cured. And so this is going a little bit slower, but I'll let it play for you all. You can see, again, that you'll shortly be seeing the suprarenal stent, which is 35 millimeters in length. That should be coming up here shortly. You can start seeing them there. SMA, we'll see our renals to the right and the left. As we're coming down. And then there is the polymer. So that's the first, and that's where we're obtaining our seal, is a polymer. See the second ring. And then after that, this is all the main body where there's just PTFE, and then you get the limbs that come down to each respective hypogastric artery. And so this is what it looks like 4-month follow-up. Again, this is what the polymer looks like. Again, this is in coronal imaging with the adaptive sealing zone to allow us to basically conform to the patient's own anatomy. That's what it looks like in axial imaging. You can see that after even just by ballooning, there is good apposition. Aneurysm has actually gotten a little bit smaller, and that's what it looks like again on 3D MIPS imaging, where again, the mid portion here, you don't really see anything. People tend to worry about that, but again, it's completely intact, and there is no evidence of type 1A endolysis. Here's another patient. I'll play this for you all. I guess it's like a bunch of 82-year-olds here, but independent. A woman who presented with a 5.5 centimeter aneurysm, actually had abdominal pain, so she was actually symptomatic. You can see some degeneration of the distal thoracic aorta, and then it kind of goes back to diseased supraceliac segment. And then here we are with a paravisceral segment, and then angled and a large aneurysm for her. Elderly woman, very thin. Coronary disease, hypertension, hyperlipidemia, and chronic kidney disease. Again, I would consider a symptomatic aneurysm due to abdominal pain, narrow distal aorta. And then I'm just going to keep going down to the level of the access vessels, because that can be also problematic, but things I don't particularly concerned about anymore, because I'm very comfortable using this, the lowest profile device on the market, to basically be able to deliver the endograft to the point of pathology and ultimately manage the disease. You can see I'm just going to let that run down to her vessels. Again, in a thin woman, disease, some anterior plaque bilaterally and small. So 5.6 here it is, so it's a little bit 5.6 in maximum diameter. And so this, you can see here again, I would consider this quite a complex neck. The neck is 7 millimeters in length. 82-year-old lady, symptomatic, very diseased. You can see in this mid portion over here with thrombus and calcium within the aneurysm sac itself. The distal aorta is calcified. The proximal neck is not very friendly, but again, less than 8 millimeters of thrombus. And you can see that 7.8 millimeters was measured out, and you can do less than or equal to 8 and involve that in your adaptive sealing technology for the endograft to obtain your seal. So the plan here, not surprisingly, there being a woman and an elderly 23 millimeter device with 16 and 14 millimeter limbs bilaterally. So let's play this for you all. So this really is the aortogram. Again, plan to do percutaneous right side main body placement, and goal to flip the limbs or to do a ballerina, and then pigtail from the contralateral side. Again, you can see complex neck, in my opinion, short neck, nasty, frankly, with a distal narrow aorta. But with 7 millimeter neck, or infrarenal neck, and less than 8 millimeters of thrombus, this is all on label, and it is on label for the delivery system as well. So up this point, similarly, get to the point that we want to deploy, which is identifying the renal arteries, deployment of the suprarenal stent, which obtains our fixation, which is again 3.5 centimeters. Following that, fill the polymer with the auto injector on the back table. And again, this will go up again, the ipsilateral limb, fill the proximal ring, come down the contralateral side. And then following that, do standard retrograde access and confirm true lumen position. Again, I do standard retrograde access. If it was complicated or was taking too long, you can always come use the up and over technique where you can snare an 014 wire. This is all built into the endograft. So if you're having a challenging time or there's difficult angles to try to be able to cannulate, you can just pass a wire retrograde and the ipsilateral side will come out the contra side, you snare it, and then can basically go up the contralateral side. So it really makes it not quite nice and very easy, frankly, in more complicated aneurysms. Measure our iliacs bilaterally, so tenor imaging. Just to show you here to the screen right, I think this is very important. This is one of the iterations that happened with the Alta that was not present on Ovation Prime, or Ovation IX. You can actually see that these limbs, these little markers, these 4 markers, are offset, and that's something after a lot of discussion with the physicians and recommendations, because they used to be parallel to one another, and now they're offset by 5 millimeters. So the contralateral side is lower, easier to see, so you can cannulate. And when they were similar, sometimes you would cannulate and actually enter the ipsilateral limb by mistake. So over here, with them being a little bit offset, makes it easier to visualize. You can see that, and of course, the contralateral side is a little bit more lower or distal to make it easier to cannulate that limb. And then again, the compliant integrated balloon that's in there. So after deploying, you wait until you're 14 minutes to allow the polymer to cure. At that point, I mold it there, I keep it up for a minute, mold it there to get good apposition and remove any infolding that may be present. And following that, complete the ipsilateral limb deployment after obtaining the appropriate sizes. Do a balloon angioplasty. When I say angioplasty, do a balloon angioplasty up to just 4 atmospheres to get some good ironing out of the limbs proximally. And then ultimately, here's our final angiogram in an 82-year-old female with a complex, nasty infrarenal neck, 7 millimeters with thrombus. And this is our completion angiogram, who presented symptomatically with abdominal pain. And this is our completion angiogram, all done percutaneously and in the standard fashion. And frankly, and everything was on label. We had her stuff at 30 days. We'll show you a 30-day CT. She came back again. There is some aneurysmal, there's some degeneration, distal thoracic aorta. I get that, but she was presenting with abdominal pain. And so as we come down a little bit lower, you can basically see there is evidence of the suprarenal stents. The renals, there is a polymer ring, and then taking a look at the aneurysm, that's from his instrumentation, that bubble, and then there's essentially complete exclusion of the aneurysm sac. Of course, she has no further pain and no evidence of endo leak. And you can see here the distal aspects are good outflow tracks with good positioning. At 30-day follow-up again, you can see our adaptive sealing zone, which involves some calcium. Very good position there. The maximal aortic diameter has gotten a little bit smaller compared to our preoperative imaging. And then at the aortic bifurcation, we have our nice 8-looking sign. So good flow with the bilateral limbs. And then, of course, a nice 3D rotating picture to show you. Those are the 2 major cases. I'm going to just show you just a couple more, just easier. Like everyone's always like, well, you're using these complex cases, the older lady, very tiny vessels, or the angle is really terrible, this is very challenging, and so forth. Yes and no. I mean, I also use them for run-of-the-mill regular cases, workhorse cases. I mean, I know nobody sees aneurysms like this. I don't know how I got lucky and I found an aneurysm like this. I get it. They never show up, but they did. And again, I did not necessarily have to, leave the device, a polymer-based device, for the challenging, complicated, everyone says no cases. I use them as a workhorse. And so in this case, the patient had a longer infrarenal neck. Frankly, my goal here was to save the accessory renal. I didn't see a reason. I thought I was going to get enough seal because I didn't have to use 10 or 15 millimeters. I only needed that one position of that 7 millimeter mark. And so my goal was to be able to save the accessory renal in this patient. And again, just to show you what it looks like, there, we're able to place that there. You can see the main left renal is there, the accessory renal is here and here. Quite happy with that. And I was able to obtain seal, complete exclusion of the aneurysm sac with no evidence of endo leak, well positioned. Very happy with this in a case that, had a relatively straight neck and not, the crazy complicated ones that we always leave these devices for. Another one to show you, again, this is much more complex, obviously. a very ugly looking neck, if you will, tortuous again, but considering the juxtarenal angle, at this point, able to deploy that. And this is what it ended up looking like at the completion with, again, complete exclusion of the aneurysm sac and no evidence of endoleak, maintaining this all in, a percutaneous PVAR type technique. So I think I really spoke a lot, so I apologize if I just felt like I'm talking and talking and talking, but I appreciate everyone's attention. And if there's any questions, please put them in the chat or please feel free to talk, and I'd be more than happy to answer the questions as much as I can. So thank you all for your attention.
Yeah, thank you so much, Dr. Mouawad. This is Eric with Endologics.
Erica.
Had a couple questions come in already.
Yeah.
So one of them that we had was, what is your experience with Alto and angled necks compared to other stent grafts with your experience?
Yeah, I mean, yeah. So I use this a lot. I've used all the devices. I think it's important to be clear about that. But I found using this, I don't have to worry about trying to retrograde cannulate. I found that I'm able to obtain the seal quite nicely. I think it tracks the tortuosity of the vessel quite nicely. And so this has been my preferred device for severely angulated necks. I know there are some other self-expanding ones that are conformable that you can always decide on based on what the infrarenal anatomy looks like. But for necks that are significantly tortuous, I find these work very, very well, obtaining the seal. And then ultimately, after you obtain a seal, if you have any concern about trying to cannulate the gate, the contralateral gate, there's always an opportunity here for using the up and over technique like I discussed previously. So I think there are multiple benefits of using this. But again, I find that usually when you have severely angulated necks, you don't have that much room where something gets crushed or not. So I find that these work very well.
Great, thank you, thank you. I had another one for you. It was, how's your treatment logarithm changed in how you treat patients now, since now that you have a 13 French delivery system on a device that treats 7mm necks?
Yeah, so I mean, really, it's been a game changer for me. Like, I don't worry about, in the beginning, you have to worry about all the access. You have to worry about a variety of things. Yeah, this over, I think there's some data to show this. I think maybe 70 or 80% are all technically of aneurysm would technically be considered all on label using this device. So I don't worry about access, and I don't worry about the infrarenal neck as much as I used to. Frankly, like I said earlier, this has taken away a lot of my fenestrated work. Because I'm very comfortable with the device itself, with planning it, with deploying it, of course, and understanding, the metrics of where to place the polymer. And of course, I encourage you all to talk to your reps who, in the beginning, just become more comfortable with that. But if you place it where you want it to place, and you're very particular about that, really, in my patients using polymer-based technology, even Ovation, previous devices, even up to multiple years out, have really done very, very well with really no concerns for repeat interventions like I've seen or I've had to repair in other devices.
Great, thank you again. Had another one for you. So there's been some really good data that shows the Alto limbs have very low thrombosis rate. But what do you think that's attributing to that?
Yeah, that's a good question, actually, Eric. I mean, I think their flexibility, the conformability really allows the flow to remain as laminar as possible, even though they're PTFE. So, I've really not seen, I'm going to knock on wood here before I jinx myself, but I really haven't had any limb occlusions. And I have not had limb occlusions using the Ovation limb, because they manage tortuosity very well, and they are, I don't want to jinx myself, but they're almost like kink resistant in the sense that they really maintain the laminar flow.